results of our study. The founder of Federal AIOC Procedure Institution, the world-renowned academician Professor Federer, told beautiful eyes for everyone. That's why we try to provide the best possible vision in any case, even in the complicated cases. Such could be the attempts to perform the refractive disorders correction in such patients who suffer from the open-angle glaucoma. Such discussion raised a lot of questions. For example, who can be operated? Which surgical technique can be used? Which IOP measuring methods can be used preoperatively and after the refractive surgery? And of course, is it safe, effective, and can provide this long, stable refractive results? The aim of our study was the elaboration of optimal refractive disorders correction technology in patients with compensated primary open-angle glaucoma, including pre-op examination and preparing, surgical technology of ametryopic correction, and post-op care. Criteria of inclusion to the investigations were divided into the refractive criteria, which I will talk about later, glaucoma criteria, which included as confirmed stabilization more than 1 year, compensated IOP, and early to develop stage of glaucoma process. Criteria of exclusion were glaucoma progression, somatic decompensation, other eye pathology which contraindicated to the refractive surgery, and so on. Totally, we include 141 eye, and after the exclusion, 111 eyes were operated. According to the refractive criteria, we divided the patients in 4 groups. The first one has severe nasoptropia and were not able to have a good glass progression. Another group was with lens intolerance. Another group which have induced refractive disorders after pre-op surgery such as cataract surgery or radial keratotomy or penetration keratotomy, and so on. And the last one were the patients who have high visual requirements according to the lifestyle or professional. If we're talking about the IOP control before and after the refractive surgery, we are well known that applanation tonometry pattern depends from the corneal thickness. In case of damaged cornea, the tonometry is less significant compared to the contact methods. In Russian, we use a so-called tonometry for the contact methods of the IOP measuring. Previously approved that ablation of about 31 millimeter of central corneal tissue result in 1 millimeter decrease of IOP measured with Maklakov tonometry. That's why we suggested so-called individual IOP profile according to the volume of the ablated tissue for measured with Maklakov tonometer for the IOP control post-op compared to the pre-op data. If the patient had IOP subcompensation, hyperpigmentation of Schnell's canal, or combined hypertensive therapy, we performed SLT. It was performed in 43 eyes and no complications were, and mean IOP decrease was of 4.6 millimeters 1 month after the SLT. Well known that a lot of patients who suffer from glaucoma have also different stages of dry syndrome. We also examined our patients with ocular surface methods evaluation, and was shown that about 68% of glaucoma patients have different stages of dry syndrome. All patients were cured by the specific therapy, and also if we seen the compensation of the ocular surface parameters, the refractive surgery performed. When we are talking about the preferred method of the refractive surgery correction, of course the ideal method should be should be minimal IOP increase during the surgery and minimal corneal and mechanical damage. Of course, logically, is think about the PRK, but it needs long-term post-op steroid therapy and high risk of post-op haze. That's why we choose sub-bone femto LASIK, because of the less and slow IOP increase during the surgery, less corneal biomechanics damage, and high predictability and safety. Why femto? Because of the uniform flap and high predictability of the corneal flap thickness, and of course because the less frequency of the post-obtruous of the flap and less depress under the flap. We've also shown that sub-bone femto LASIK influence less biomechanical damage compared to the mechanical one. It due to the operation is performed within so-called strong cornea. So bone femtokeratocondylosis decrease the risk of post-op corneal ectasia due to the possible IOP increase. So bone femto LASIK was performed in 111 eyes, and 90 microflaps was performed with femto-LTE, and ablation was performed in Russian-made exam laser, which were created in collaboration with our institution, Microscan 500 CATS. Exams were since 1 day to 4 months after surgery. The modification of post-femto LASIK care included shorter steroid treatment since 3rd day post-op, hypotensive drops, and IOP control. Also control of glaucoma progression. Data demonstrates wide range of refractive disorders should be corrected. Post-op, in all patients, we try to create the lower minus due to the age. That's why the best uncorrected visual acuity is sub-maximal. IOP dynamics shows the quite stable IOP in all groups and were correlated to the individual IOP profile and volume of the ablated cornea. In 2 eyes and days post-op, we've seen the IOP increased, steroid induced, and steroid was changed to the non-steroid drugs, and IOP were compensated. 4 eyes, 12 to 6 months post-op demonstrated IOP subcompensation, which were needed for the SLT. No progression of glaucoma verified by SLT occurs. Other complications. Dry eye syndrome was the most frequent complications, and it was more than 50%, but clinically significant only in 20%. Neurotrophic epitheliopathy in 15%, and flap disaggregation in 1 eye. One of the clinical example, the patient after radial keratotomy, which is seen in the confocal microscopy, and the induced hyperopic shift were operated after the SLT compensation of the IOP, and we've seen quite good visual result and stable IOP and visual result after 1 year control after the surgery. Next, patient with a moderate myopia and lens intolerance she demonstrated the normal parameters of ocular surface, but 1 week post-op we see the severe dry eye syndrome, which were needed for the activated hyaluronic acid, lubricants, reparative therapy, and compensation of the ocular surface was reached only one month after surgery. But 1 year after surgery, this patient has high accurate visual acuity and stable IOP. So the results of our study shows that in case of compensated primary open-angle glaucoma accompanied with refractive disorders, sub-bone femto LASIK is possible, but only in case of careful patient selection, pre-op, pre-pairing, and post-op strong control. Thank you for your attention.
Thank you, Dr. Natalia. I think even with the femto LASIK, the IOP does rise, and it rises quite high.
Quite high, but compared to mechanical keratom, then
it's 60 millimeters instead of 80 millimeters, even if it's for a very short time.
Yes, but we also, it wasn't included in this slide, but we also suppose that the rise of the IOP can be realized in the disturbance of the blood supply to the optical.
Yes,
also because the stimulation and no
long-term effects.
Yes, so that's why we suppose that this technology may be not so dangerous in that case.
So refractive surgeons can be very happy that they can think about doing refractive surgery, especially the femto in patients who have compensated. Please remember, compensated, controlled POAG. I'm not sure if anybody in the audience has any questions or any comments to make about this talk, but I think we do have time, and since this was the only glaucoma session that I could see where there was possibility of discussion, we'd be happy to take any questions. And maybe one of the things that leads on from this is the steroid response. So if anybody has a comment to make about steroid response or about LASIK, please feel free. Yeah, Dr. Shushmita.
In our center, at least, the cornea surgeon...
Just have a mic that if people wanting to listen to you behind you, Shushmita.
The cornea surgeons avoid it, of course. Thankfully, POAG occurs in the presbyopic age group, so they're not such a problem. The JOAGs are a problem because JOAG, as it is, a difficult disease to treat, and they want LASIK. But what they do about the steroid is give them a challenge of 4 weeks before, always. That's the standard practice. 4 weeks challenge of dexamethasone. Only if we document no rise of pressure and we document they're not steroid responders, they will go.
Which would be what percentage of juvenile open-angle glaucoma? Because juvenile open-angle glaucoma does tend to respond very highly to steroids.
Yes. To be frank, most of them are dissuaded. And the ones who really, really insist, few of them, yes. Out of about 5 or 6 who have had to undergo, 2 were responders, and they
I think Professor J.C. Das also works in a center where a lot of refractive surgery is done. So we could have comments from him. And any other questions you have regarding glaucoma of any kind, medical therapy, surgical therapy, anything you want. We do have Professor J.C. Das, the President of the Glaucoma Society of India, Dr. Shushmita, the Secretary, and a lot of other people. So we could help you with any problems you might have.
In fact, doing the refractive surgery in presence of glaucoma is a very tricky situation. Because the fact that there may be a transient rise of pressure during surgery, during the LASIK, whether this is femto or otherwise. So a transient rise of internal pressure may be enough to knock out some of the nerve fibers. So that is one factor. Second is the steroid response post-operatively. That is another big factor. But the most important factor is the intraocular pressure regulation or control of intraocular pressure post-operatively becomes very difficult. That is the only factor we depend on to control the progression of the disease. So the moment that we feel that the intraocular pressure control becomes erratic, we do not know how much change it has brought about in the corneal thickness as well as its elasticity, biomechanical properties. So intraocular pressure, depending on the intraocular pressure, becomes little tricky and maybe little difficult. This may be tolerable in cases of the ocular hypertension in some way, but in cases where there is already some amount of glaucoma suspect because of this coping, so things becomes even more difficult. Especially for a patient who is younger in age, it becomes really challenging to follow these patients till the age of 80 or 90. So keeping that thing in mind, maybe very often we discourage any type of refractive surgery in such cases.
Thank you, Dr. I think the take-home message probably from this is that you can do it if the patient is really motivated and your glaucoma is controlled. But as far as what Professor Das was saying about following patients up, I think what is important is that the corneal biomechanics change completely
sir, I just wanted to know whether still we are using bipolar or have we changed some other suture because it is kind of different.
Thank you, Shani. You can hand it to Shweta that she'll start answering your question.
6 or white?
6 of them.
No, I'm using 10 on that.
Sorry?
I'm using non-absorbable.
Non-absorbable 10 ohm.
Only 2 pyrotonic sutures and 1 center.
So, Shalini, you're using a limbus-based flap or a phonics-based flap?
Phonics-based.
You're using a phonics-based flap. Dr. Panda?
I mostly use limbal-based and I go for it.
They can't hear you. Tell me, I'll
Yeah, very frequently I use limbal-based flap, and there I use, because the suture material is quite a bit, so I use 10 on nylon, 10 on vital, and if sometimes 8 on vital, most of the time. The idea is basically because you need less of for the material there, and 6O will not be accurate for that. But if you're using a limbal-based, if a phonics-based, that you're putting the wing suture, then you need a little stronger suture actually. If they're 10 will not work there. They're 8 or 6 will be better. So I think you have to use it according to your procedure.
Ma'am, I would like to ask one question. We can use glue or not in place of these sutures?
I think glue, have you had any experience with glue? You're talking about phonics-based flaps.
Yeah. I haven't used much actually. I have tried in a few patients of glue, but I think it's better. You feel more secure with sutures actually, because you don't want to glue the blood area which you have actually created, and you don't want to block your treatment in the first place. And secondly, it's not strong enough. And post-operatively, if you want to manipulate your blood, then suture is a much better option. That gives you much more surety.
There is a rally scene nowadays. They are propagating a lot about these glues. We have to use it. You can use it over here. It's better than the non-irritant. And I'm sure about it's better.
No, but I think you need the wound integrated. That's very important. And in the trauma surgery, it's not just bluish tone. Post-operative period is very important. And then if you have to manipulate your blood, then glue is not strong enough.
I'm sure about it's less irritant.
That's fine. That's okay. But the wound healing still takes.
It's not really that less irritant. If you ask patients in whom you put a glue, it's not less irritant. And you'll find that there will be a certain amount of inflammation around the glue as well. But I think what Professor Panda was trying to tell you is that for those 4 weeks or 8 weeks after the trabeculectomy, there are many things that probably need to be done, including a globe massage. And if you put a glue, I'd be very, very hesitant to ask a patient to do a globe massage.
Yeah.
So it's safer to put a suture, less expensive in this country. Why are we looking at glues?
Okay, ma'am. Thank you.
Yes.
Moreover, glue they spread on entire the surface. So like if you want to put suture only on the edges, you don't want whole of the flap to stick onto the swivel flap. And glue they generally spread it, they will stick whole of the flap on the slider. So probably that won't be very good for our decks.
I don't think many people use, and if you use, you can tell us what your
Make a thin film of this glue, then it won't. It won't spread like this. What is not like a oil.
No, it's not like an oil. You can put it in a particular area, but what Professor Panda was saying is that when you put it under the conjunctiva, you're also gluing down the scleral flap. And if you think about it, the aqueous, 80% of the aqueous comes out at the limbus. Because you're making your ostium at the limbus. So if you then glue it down, which is what we do when you put releasable sutures, you're closing that area, but you're removing the releasable within 3 days, 1 week. But with your glue, it's going to remain. So you're actually going to get much less aqueous coming out and much less of formation.
I wanted to ask, post-refractive surgery, which tonometer is added to major eye? Most of us have apprenticeship tonometers. With the refractive surgery on the surgery, what is the ideal tonometer and what tonometer should we use?
No, there's no formula required. Nothing. Don't get into complications which nobody understands yet. Basically, the IOP that the patient had prior to your refractive surgery. That is most important. You take that and you know what is the response of the patient over time using that particular target IOP. 6 months after your refractive surgery, you've allowed the edema edema to settle down or the inflammation to settle down. And at the end of 6 months, you again do another either diurnal or a number of measurements to say that pre it was 16 millimeters, post my readings are coming to 12 millimeters. So you now know that your 12 6 months post is equivalent to the 16 pre-op. Am I making myself clear? You're reforming your baseline. Your baseline is again now going to change. Initially, pre-op it was say 16 on maybe just a Timolol, and now post-op it's 12 on Timolol. But what you have to tell yourself is, regardless of how thick or thin the flap was, your 16 pre-op is equivalent to the 12 post-op, and from there onwards you're going to make sure that the pressure remains the same if the patient was well controlled pre-op. If it wasn't controlled, then you need to drop it below 12.
We are now going to take into consideration the corneal biomechanics.
We don't understand the corneal biomechanics at the moment. Thickness is only one of the factors. By the time you do a LASIK, you're causing fibrosis, you're causing other changes, so we don't know what those changes are. Each individual, the changes are different. We also have the ORA, which gives us absolutely no joy.
We don't know how to use that information.
I think the ORA was sold to everybody saying that this ocular response analyzer is going to be the end all of our problems with the cornea. Basically, it's just the start. We don't understand what to do with the numbers we get. Any other questions? Everybody's glaucoma management is wonderful. I think in that case, I'd like to give.
I'll ask a quick question, man. Prognosis is same from the years. What the glaucoma people are doing?
Sorry?
From last 20 years, from last 25 years, how many medical science? Prognosis is the same.
Not at all, not at all. I joined ophthalmology in 1980. In 1980, the only things available to us to treat glaucoma were epinephrine, pilocardium. In 80s, we started having Timolol. Alright? In the 90s, we got the prostaglandins. So the number of people we were able to control medically has increased exponentially. As far as the surgery is concerned, I think we are understanding the trabeculectomy a little better. We are modifying the trabeculectomy a little better. So in fact, one of my residents presented a paper, I think 2 days ago, where we have, if you take qualified success into consideration, we had 100% success of trabeculectomy. And the reviewers or the judges sort of said, how can you have 100% success? But the thing is, if you actually analyze your own cases, you'll find that the trabeculectomy works extremely well. And as was being projected by all the speakers, the success rate is in excess of 85%. What we did find when we looked at patients 5 years, 10 years down the line, that the progression is actually seen in only 10 to 15%. The other 85% these days we are able to control very well if the patient is compliant and comes back regularly for a follow-up. If they are lost to follow-up, if they can't afford medication, then quickly do surgery. Don't hesitate to do surgery. Surgery is not a bad option. Surgery is a good option if you know how to do it. Dr. Pathak, what would you say? Prognosis?
Yeah, I think you said the prognosis is the same. Actually, it's the same if you don't treat. And for that, we have to pick them up early. That's an early diagnosis and effective treatment. That alters the prognosis. So it's not the same. So things have definitely become better. But the key to is that they get them early. So pick them up early. So if you are picking up a patient, say, when it's already 80%, 90% is already damaged, then you just have very small opportunity, which you have to take care. And over a period of time, because of the age-related attrition and also some progression, you may end up with disable line zone. The patient may end there. But if you pick them up early, the prognosis is
And the other thing I think we all need to completely forget. Forget this whole business of 20 and 21 millimeters of mercury. If you remember that your normal intraocular pressure is between 14 and 16, there is no reason why you should leave any glaucoma patient at a pressure higher than that. Okay, so if you're going to worry about, has my patient reached 20, you're going to lose a lot of vision, you're going to have a very poor prognosis for your patients. Please drop your intraocular pressure. The target IOP should ideally be at least somewhere around 15 to 16, even in the early glaucoma. Okay, so I think this 2021 has actually made us completely mismanage our patients initially, and now we're all coming to the point where we say, not 20, not 21. The more severe the glaucoma, it should be 10. The less severe the glaucoma, it should be around about 15. Yes, sir, you asked me.
Yeah, it's very interesting to see that you could achieve 100% results in the surgery. Can you give the, I didn't hear the connection. Can you summarize, apart from good input, like in surgery, what you do in the past for achieving the results?
I do pretty much what Dr. Pandav has said. I do a limbus-based flap because most of my patients, I work in a government hospital, most patients are poor. Getting them back repeatedly for a review is very difficult for me. So a limbus-based flap provides me with good closure, a bleb on the first day. I do use releasable sutures in almost 80% of my patients, not all. I make sure that the limbal extent, the circumferential extent of my flap is at least 4 millimeters, if not 5 millimeters. The internal ostium is 1 into 3 or 1 into 2.5. I do a good iridectomy. Alright? And in the post-op period, my advice to all patients is to continue the antibiotic steroids at least for 6 to 8 weeks. Most of the time it's 8 weeks. Right? And any sutures that have to be removed are removed within 3 days or definitely within 10 days. I think it does extremely well. It's just a question of you looking at your own cases and saying this one did well, this one didn't, and why did this one do well, and why did this one? Professor Das, would you just let me give these lectures, please? Yes.
These three eminent speakers, and for reasons of time, Dr. Sudeep Das is going to be presenting first, and his topic is on customized cataract surgery. As many of you may know, Sudeep is working in Narayan Nethralaya in Bangalore and is a very busy, well-established cataract surgeon doing the entire gamut of cataract surgery. Over to you, Sudeep. Can I invite the other panelists, Dr. Joe Vakil, Dr. Khurshid and Dr. Deepan, to join us on the dais? Dr. Deepan Desai.
afternoon, everybody. I'll be talking on customized cataract surgery, and basically a lot of it is how we work with the eye trace and with the other equipment that we have to sort of deliver what the patient would want. So my dad is a doctor who's 89 years old now, stopped practicing a long time back. But in his days, this is what the doctor was like. I remember as a kid seeing him going around and, the halo which was around him and how people worshipped him. He was a surgeon. And if you had a cataract, I suppose these were the things. I mean, it's just you were told something and whatever it is, the patient had no other choice. There were almost no private hospitals. But now it's different. Our patients come better informed often than we are. And if there is any unhappiness on his part, which may not have anything to do with the quality of the treatment, we could face the consequences. So what has been the change? Cataract surgery has evolved from just treating the patient's functional symptoms. That is, he came to you not seeing very well, or he was almost blind, and then he started seeing. He was very happy with that. Now, it's the commonest refractive surgery. So we're talking about delivering 6/6 and beyond. And if we are talking about multifocals, then in 6 also. And patient's everyday visual functions or his needs determine satisfaction after the surgery. Obviously, it's not just the raw vision that we get on a Snellen's chart. And there are subjective tools. The VR14 index has been there for a long time. There have been modifications of that, many of them. And these help us tailor outcomes to the patient's perceived needs. And then we have now also objective tools like the OCAS, eye trace, etc., which help us to actually analyze, understand, and improve outcomes by understanding the optical system of the eye and trying to match the implants with that. We can't be like this. When the T-Model Ford came out, there was a clamor for cars of other color. And Henry Ford said that they can have it in any color they want so long as it's black. We can't do that now. So we come to this concept of Zernike optimized cataract surgery, where we match the implanted IOL with the lower aberrations and higher aberrations. So there's no astigmatism. We could go in for a non-toric IOL, astigmatism, toric IOLs. And then we could measure the spherical aberrations on aberrometers like eye trace. And if it's positive, we could go in for various IOLs like the Technis, Acrosoft, Hoya, Zeiss, which all have a negative spherical aberration of various degrees. So you're left with either no spherical aberration overall or with a small positive spherical aberration which would probably give some depth of focus. And then you have the Boston long which doesn't alter what's on the cornea. And then you have the negative eyes with negative spherical aberration where we have to go in for what is called spherical IOLs, but they actually have a little positive spherical aberration. And yes, the Hoya has the EDS, which we do not have in India as of now, which has a fairly high positive spherical aberration. And what do spherical aberrations do in the human eye? So the aging cornea has, a young cornea would have a sort of negative spherical aberration, but the aging cornea has a positive spherical aberration. And the cornea remains about the same. The lens changes with age. So the positive spherical aberration of the cornea is not compensated by the lens, which also has a positive spherical aberration. That's the cataractous eye. And when you implant a traditional IOL, it does the same thing. So it leads to a high positive spherical aberration for the entire eye. And the first generation of the aspheric IOLs which came out were negative spherical IOLs. They actually corrected this. So what does a positive spherical aberration do? Basically, the power of the cornea increases as you go from the center to the periphery. So the more peripheral rays tend to focus in front of the retina. They become more myopic. And the traditional negative spherical IOLs correct this. And by doing that, bring about a real pinpoint focus and improve contrast sensitivity. And when the IOLs are well-centered, it really doesn't matter. So here we have a spherical IOL. If you can read the numbers, they're all pretty good. And this is a well-centered aberration-free IOL. Again, the aberrations are very much under control. But when the implant gets decentered, the advantage of this aspheric IOL could be lost or even become a disadvantage. So it actually could behave worse than a spherical IOL. So we know that the first generation of the negative aspheric IOLs, they correct the natural positive spherical asphericity of the cornea, and they do provide good or excellent quality of vision when centered on the visual axis. But they are sensitive to alignment. While the zero spherical aberration, what we call the aberration-free IOLs, they do not correct the natural positive spherical aberration of the cornea. They do give a better depth of field, and they are not very sensitive to alignment. And we have a very recent addition in India, at least, the one which is called the Hoya ABC optic, the aspheric balance curve design. It reduces the corneal positive spherical aberration, but because of its design, it does tolerate some amount of anatomic misalignment, better than the other IOLs. So in the first one we have, this is the regular IOL, and if you can see that from 0.2 millimeters from the center of the optic, the aspheric portion of the lens starts. While in the ABC Hoya, it's from 0.5 millimeters away. So basically it will tolerate a decentration up to about 0.5 millimeters compared to the others, which are only about 0.2. And we have done some studies on these decentered IOLs. So this was a decentered spherical IOL. The aberrations are somewhat high order aberrations. And this was a decentered IQ. It's a lot less than that. But a decentered Hoya is absolutely amazing. It's like almost a tenth of what you have on the IQ, even though it's decentered a little more than the others. So leaving that alone, the aspheric IOLs, we can go ahead to the multifocals. I'm not actually going to talk on multifocals, but how to sort of decide on who to go for a multifocal and who not to go for a multifocal depending on the eye trace. So there are various options. We have these accommodative IOLs, but at least in our hands, that's something that I was really looking forward to because it's the most physiologic, but somehow it just didn't work. It didn't have enough accommodation at all. So at least as far as my practice is concerned, they have totally disappeared. We have the Presby LASIK. They're again promising, somewhat unpredictable. Camera intracorneal implants, great results, but there is, one eye at least, implant only one eye. There could be possibly effect on your night vision and some loss of field. So as of now, multifocal IOLs with all their problems are still the best bet now. But before we implant a multifocal IOL, we have to differentiate on very important thing. We have to differentiate between corneal and lenticular aberrations. So this patient is absolutely perfect. You see this is what is arising on the lens. So he has some aberrations which are on the lens, which will obviously disappear after we remove the cataract. This cornea which is perfect. So overall, whatever is overall, the aberrations are arising only on the lens. Well, look at the next one. So you can actually get various ways of looking at the eye trace. This is the Snellen's chart view. So it's showing us approximately what the patient will see the 20/40 line as. So if you see the lens has some amount of aberration, the cornea is really bad. So if you look at the total, probably most of it is arising from the cornea. This guy is of course going to do really badly if you put in a multifocal IOL which already has a compromised optic. So our results with multifocal IOLs have been pretty good for distance and for near. But what I would like to show is some of the problem cases that we had. So we have this 55-year-old gentleman. His wife is a doctor who's one of my wife's best friends, and unfortunately he ended up with all these problems. So, bilateral multifocals, he has like unaided distance vision of 6.6, unaided near vision of N6, but he's very definite that the left eye vision is very blurred. I have his drawings, I should have included that, what he sees like. He's an engineer doing extremely well. You go to his website to realize what all he's into. And initially I just use lubricants, use cyclosporine, in 6 months or 3 months you'll be alright. It's like more than a year now, and he doesn't come very often, which is not a good sign. But he's still not happy. And then we got the eye trace, and then we put him on the eye trace. So if you see his right eye is actually doing pretty well. There's not much of aberrations anywhere. If you look at the left eye, cornea is still very good, but look at what's arising on the lens. And this is what you would see 2040 Snellen's letter as, which is pretty good in the right eye. Left eye is terrible, but look at the cornea, it's so fantastic. So he didn't have a problem to start off with, I created it. And if you look at the 2070, again, the right eye, left eye, it's really bad. I really do not know why this is. I'd asked him to come back for a dilated checkup because his rings are pretty much centered on the pupil, but then I want to see whether it's centered on the visual axis or not. He hasn't come back, so obviously he's not very happy with me. But I would like to, so these are things but at least it helps us to decode what is happening. So I know, I've actually given an option that I'll pull out your multifocals and I'll just put in a monofocal. And he seems to be considering that. And now that I've had that experience, I put all my patients on the eye trace before surgery. So this was a gentleman who is an avid golfer. And his problem was, he says that when he putts, he can see the ball. When it lands, its ball seems to split. He sees two. It's very, very mysterious. So I don't know what it was. And he was saying that somebody had said he could undergo cataract surgery, multifocal, all that. And then when he put him on the eye trace, look at this. His cornea is pretty bad. His lens is also bad, but look at the final result. The final E is really good. And if I touch the lens, it will completely manifest. If I touch the lens, it's going to completely manifest what's on the cornea. And he's going to be extremely unhappy. So this is a bigger. So one is actually, the first one is the defocus, which you might be able to take care of because they're going to correct the spherical error. But the other one is the spherical aberration. So that is also not very good. It's sort of neutralizing it to some extent, the total. Then we come to the toric. I won't really talk on the torics, just a few strange cases. So there are various torics available. And we can use torics for, even cases which are not routine indications. So we had this lady who was post-arcade. And this is what, obviously, like many of the arcades, she had become the cornea keeps getting flatter. And she was highly hyperopic. And this is what the topography looked like, very, very flat corneas. But if you're careful and you check the proper, the central case and all that, and use the ACR's calculator, you can, like in this case, end up with pretty good results. This was another thing it helps us is to refine our results, enhance our surgery. So there is something called the toric IOL enhancer or something like that, probably Joe Vakil, I forget, with the Zaldivar caliper. So here was this patient who had a toric multifocal IOL, and his manifest refraction was 1.5, that's the cylinder at 50. Obviously, he's not very happy. His near vision is still good. And on the slit lamp, I thought that his axis was around 170. When you put him on the eye trace, it's showing around 161. So obviously, when I was doing the marking, we do a sort of freehand or on the slit lamp, but whatever, it can go wrong. And as you can see that there is a lot of astigmatism, which is on the cornea and also on the lens. But instead of cancelling each other out because of the wrong axis, they're actually adding onto each other. So the final result is a lot more than what he has even on the cornea. But there is this toric IOL enhancement module where it tells you that if you can rotate the IOL by a certain amount. So here it tells me that I have to rotate the IOL clockwise 133 degrees. Or if I can rotate it other way around, it's not easy, 47 degrees. Then his total astigmatism from 1.37 1.34 would actually come down to 0.18, which is pretty acceptable. This I had actually got the images just 3 or 4 days back. So I still haven't attempted this, but I'm really keen on trying it out. I told him he's willing to see whether it really works. It should. This is what I just came to know from Joe Vakil. It's something that really excites me. Because like I said, that we can go completely wrong when we do a marking, whichever way we do it. And so this is something which helps us to avoid that. So we take the results of the patient on the machine, on the eye trace, and we sort of create a plan. Then let's say on the table we can sort of review the plan. We can put a mark on the eye, as in this case. So we've done a marking, but then we can actually check whether the marks are in the right place or not with the eye trace. So it's already taken the picture in the OPD, then in the OT also it does the same thing. And it will actually sort of, you draw a line from this, from the corneal, one corneal limbus to the other, where the marks have been placed. And then you ask the eye test to check whether your marks are right. And here it tells you that it's off by 8 degrees. You know, this is something that is, you know, it gives you so much of peace of mind. So you know that, okay, my marks are wrong. It's very easy. You already have a mark. It's very easy to mark 8 degrees off, instead of trying to go for arbitrary 0 or 90 or 180. And you can, like half an hour or 15 minutes after the surgery, you can actually sit the patient down on an eye trace and check whether the IOL is in the right place or not. I'll just finish with this extreme customization. So this is a patient who came with partial aniridia, very little rudimentary iris here, and there was a significant anterior and posterior subcapsular cataract, fairly young girl. And the topography showed significant astigmatism. There's almost 2.5 diopters of astigmatism. And we used the online calculator for choosing the IOL model. And then we went ahead with a phacoemulsification with aniridia segments and a toric IOL, all 2 aniridia segments and a toric IOL in the back. And the amazing thing is, this is what you would like to see on the eye trace. So this is what is on the lens, this is what on the cornea. It's almost cancelling each other out. So the total overall astigmatism is almost 0. And so this is what is on the lens, this is what on the cornea, completely neutralizing each other out, and the patient is seeing pretty well. So this is what the patient looked like before surgery. This is what she looks like now, or the eye looks like. And it's pretty stable. And the vision, obviously, she had some amblyopia at the 6-12, but it's absolutely fantastic. So routine cataract surgeries, they're just based on analyzing the lens opacity. And the IOLs could only obviously correct the lowered aberrations. We could just correct the spherical aberrations, later on the cylindrical errors also. But then we did have a lot of surprises. But now we can actually, you can also take the aberrations into consideration and reduce the number of unhappy patients. Thank you.
Thank you, Sudeep, for that comprehensive presentation. Any comments from the panelists? Dr. Kushi, Dipen, Joe? Do you want to add? Any questions from the audience? We just take a couple of them because, yeah, go ahead, please, Dr. Kashyap.
Yeah, how actually do you mark a 90-degree or 6 o'clock position, and how do you think that IIT is doing a better job than you, and what is the technology? Because what I feel is that there is no mark, there is no landmark, but by which can you say that it's a 6 o'clock position or 90 degrees?
No, when the patient is looking straight, even when the patient is looking straight, so this basically takes the conjunctival vessels into consideration.
So when adult blood vessels, they are not at 90 degrees.
No, it doesn't have to be.
I want to know what is the basis on which you said that it is a 90 degree or a 6 o'clock.
That I think Joe will be able to tell you. But the thing is, the vessel doesn't have to be there. I can put a mark anywhere and the machine will tell you, okay, it's at 90 if the eye is looking straight. But here, when I'm doing it manually, even if the patient is looking straight, I can go wrong with my marking.
No, basically the idea of this machine is you mark at the 3 o'clock and 9 o'clock meridian. And whatever device you employ, whether you do a freehand marking under the slit lamp or you use an aceto bubble marker or whatever, sometimes there can be a tilt. This instrument actually tells you how many degrees off this markings that you have made by, so that you can, at the time of surgery, you can compensate for that.
But what is there in the eye trace that tells you this is 90 degrees and it's 6 o'clock position?
Yeah, it basically uses full iris.
I mean, you know about the bubble system, but you said this is a horizontal. Fine. But at 6 o'clock position, 90 degrees, which is the bar.
You can use pendulum marker, there is 90 degrees.
Pendulum marker, put the pendulum marker on the right side, you're gone. Put it on the left side, you're gone. So which is the perfect position? By which you said this divides the coin in half an hour. The pendulum marker is, okay, fine.
Just one moment, Dr. Joe has a...
You ask how the Tracy does it, because in the pre-op exam, what the Tracy's able to do is when you do a pre-op exam, it has a color camera, gives you both the topography and the color image of the eye, all the detail, the iris detail, vessels, every information of that two-dimensional image is analyzed with the topography. So when you go to the operating room and you have a live video from the OR microscope, you can capture a frame and the Tracy software can register the entire detail, the iris detail, the limbus, the vessels, and any other marks, and tell you exactly where the alignment is of that axis of topography, which you can actually get a correction off your mark. You as a surgeon, try to hand mark the axis 84 degrees, as Dr. Doss showed. But the Tracy can register all the information within the two frames and say you're still 6 degrees away. That's what happens in real time.
Thank you. I think we pass on to the next topic. This is by Mahipal. He's going to talk to us on the new generation aspheric intraocular lenses.
Thank you very much, Dr. Ramamurthy, and thank you, Oya, for calling me for this lunch symposium. I'll be talking about the new generation aspheric IOL, and I'll try to keep it as simple because there are only 2-3 carry-home messages. Can we have the lights off? The lights are. As was talked earlier by Dr. Sudeep, you all know that there are spherical abrasions in the human eye. And in a young person, there is a positive spherical abrasion of the cornea, there is a negative spherical abrasion of the lens, which neutralizes each other, and therefore the quality of vision is good. However, when you look at an aging lens, the lens over years tends to also get a positive spherical abrasion, and therefore the quality of vision and the contrast of an old person goes down, especially in dim light conditions, and the positive spherical abrasion of the cornea remaining constant. The lens from a negative becomes a positive, and therefore it causes a degradation in the quality of the vision, as can be seen here. Now, earlier when the lenses were manufactured, they were all having a positive spherical abrasion, and therefore the cornea having a positive spherical abrasion and the lens having a positive spherical abrasion, the two compounded and the quality of vision was not too great. Now, what is the word? This is longitudinal spherical abrasion. That means that when the light is coming from the marginal area or they are coming from the central area, the marginal, as if they come on a focus earlier and the peripheral come to a focus at a distance, what is the separation between these 2 points? Is that clear? So that is longitudinal spherical abrasion, LSA, which is equal to the where the length of the marginal rays are there minus the length of the peripheral rays are there, and this LSA for with a spherical IOL at a 5 mm pupil is normally considered to be 0.4 mm. That means that you have to compensate for about 0.4 mm being the disconnect between the 2 areas where the rays come to a focus. And so therefore the people came about what is known as aspheric lenses, and aspheric lenses actually are of 2 categories. They were, when you started with positive spherical abrasion lenses, then you came up with negative spherical abrasion lenses to counteract the positive spherical abrasion of the cornea. And then again various values have been done for these lenses by different manufacturers, because actually every eye would possibly need to be customized as to the spherical abrasion, and then there is a question that do you retain some amount of positive spherical abrasion at the end of the surgery, and that supposedly is useful for giving a depth of focus. Now, the Bosch & Lomb company came up with the idea that if you are putting a negative spherical abrasion lens and if it is moving from the center, then it is going to have a deleterious effect on the quality of vision, because you are presupposing that the lens is going to be centered and the visual axis and the lens center is going to correspond, and therefore there is going to be no deterioration. So what they came up was zero spherical. That means that from a positive spherical, people came to a negative spherical, and they came on to a zero asphericity. And when you are looking at a zero asphericity, so what they are doing is that we are not compounding the asphericity of the cornea in any manner. So whatever is the cornea, let us leave, and because it is zero across, decentration or tilt is not going to cause a problem. So this is just to show you that if you have a spherical aberration lens, then if you have if you have a lens which is here, then under those circumstances, the first one is the centered, then you have 0.2 millimeter decentered and 0.4 millimeter, and you look at the point spread function, how a point becomes distorted with a point spread function if there is a decentration. Now similarly, if there is a tilt of the intraocular lens as is seen here, and depending upon center 2 degrees tilted or 4 degrees tilted, you tend to again have the quality of the image going bad. Now these are the lenses that we most often use. The IQ or the Alcon stable, that is minus 0.20 microns, that is the lens that is used, and Technis takes it a little higher, and that is 0.27. And this is the zero spherical aberration, which are the lenses which are used by the Bosch & Lomb table. Now essentially what we have said is, A, you need to know what is an average spherical aberration of a cornea. If you have that, you try to neutralize it or leave it at 0.1. Some people say if you are putting minus 0.27, you are actually trying to bring it to 0. So this again is the question, but that is what the Hoya people, they want to keep it to nearer to 0.1. And the second thing is that you need to make a lens which should have minimal effect of decentration and tilt. Okay, so these are the two things that you are supposed to be looking at, and therefore the Hoya came up with what is called as a aspheric balance curve, ABC, aspheric balance curve, and I will just tell you what exactly this is. This neutralizes the corneal positive spherical aberration, but also tolerates the anatomical misalignment and also compensates for the optic and the visual axis not being perfectly aligned. So even if the alignment is not perfect, the lens doesn't give you a problem. So this is how the lens is. It does not have the same asphericity or the negative asphericity across the lens. Okay, that is the basic difference. So when you have this particular lens, the center of the IOL optic is minimal negative aspheric. Okay, and then you come on to the standard negative. This becomes more. I'll just show you. So this is just to show you the curve of if you are putting a spherical lens, is aberration free and a negative this thing. So as you start in the center, for any lens to have any effect, there is a slight positive over the power, and this is the bend that comes in the normal lenses. So you have the negative aspheric here, and there is a sharp fall here, and this is the degradation that happens as it goes. Now if you look at the ABC Hoya lens, slight positive, then you have a slight negative, and then you have more. So this is how it is in this particular design. So this is the ABC design, which gives you slightly positive in the center and negative between the center and the standard negative design. Okay, so you have slightly positive, then you go on to slightly negative, and then you go on to the standard negative. Okay, is that clear? So basically what you are doing is that you are looking at, if you have a high negative asphericity in the center right from the beginning, and if there is a decentration and the tilt, that's going to affect the center the most. And if that affects the center the most, that is going to degrade the quality of the vision the most. So you take it for granted that majority of your intraocular lenses are off-center. These are studies which have been shown. So you want that the center portion should be giving you the least distortion, and then you go on to the periphery. So that is what it is. And these are the zone 1, 2, 3, as I told you, between the variation as you're going to have, and this is the sinusoidal curve that you have in the Hoya. Therefore, to sum up, I would say that the balanced hybrid optic IOL of Hoya provides minus 0.18 microns of spherical aberration correction. It maintains the image quality in the presence of most misalignments, and this is the standard curve that you can see between the various lenses as to how it does, and you can see that the curve here is the best curve that you have. Just to show you that on the eye trace, if you have the IOL center, the cornea center, and the optical, these are three things: IOL center, cornea center, and the optical axis. They could all be different, and this is what happens in majority of the time. So if you have this image and you translate onto this, you can see that there is a disconnect between the optical axis, the cornea center, and the IOL center. So majority of the corneas, majority of the IOLs in patients are decentered, and in this particular case, the IOL center is 0.36 millimeter apart from the optical axis. So if you had a huge power of asphericity in the center, this 0.36 millimeter is what was the spherical aberration that needed to be corrected. So it could compound it the other way around, and it could cause the problem. Just to show you the ABC design, this is the central part, this is the peripheral part, and if you have the IOL, you can see despite any tilts that are happening or misalignments that are happening, all these remain in this zone, which is not the greater zone but the smaller zone. So if you have a decentration with a lens which is aspheric towards zero in the center or minimally negative, the discomfort or the disadvantage would be minimized. Is that clear? So that is all that they are trying to say, is that we are making different zones. The central portion, given that there are going to be misalignments when the IOL is placed, it is not going to be that bothersome to the patient, and that is what the lens stands for. So I hope I've been able to give you the take-home message that it's a balanced lens which allows you more flexibility of not causing harmful effects even if there is a decentration, a misalignment, or a tilt in this particular lens. However, personally, I think as customization for everything is going on, we still have to say as to for which cornea, what kind of residual asphericity is good, whether a positive asphericity 0 or minus, and that basing on that, you could possibly have various ranges of lenses who you could fit individually so that it gives you the best quality post-operatively. So thank you very much for your kind attention. Thank you.
Thank you, Dr. Mahipal, for dealing with a fairly difficult topic so lucidly. Any questions to Dr. Mahipal? Yes, Dr. Satyam.
Good afternoon, sir. If you take around, say, 100 patients with a little bit of decentration, is that all of them, they do complain about this effect of decentration and the difficulty in the quality of vision, or what is the percentage of people that have the problems? Do you have any RCTs to show that, or have any data?
Okay. There are these studies which go and which say that